Synchronised cardioversion is a method of reverting the heartbeat back to a normal rhythm in patients with a rapid ventricular rate associated with a severely depleted cardiac output. So this can be a decreased level of consciousness, hypotension with a systolic blood pressure of less than 90, chest pain, or heart failure. Our indications for this procedure mean a rapid ventricular rate associated with severely compromised cardiac output. So a pulsatile VT, SVT, atrial fibrillation, or atrial flutter. Contraindications for this include VF or pulseless VT, dysrhythmias with an adequately perfused patient, or digitalis toxicity. There are a few complications that can occur with this procedure. These include bradycardia, pulmonary edema, transient hypotension, skin burns, paradoxical asystole or VF. They can dislodge clots leading to stroke. Sedation that is associated with this procedure can increase risk of aspiration of stomach contents and obstruct the ability to breathe. Our special and safety considerations with this procedure can be summarised as this. So firstly, always consider other causes for the tachyarrhythmia that could be going on, whether this is hypovolemia, stress, the patient has an electrolyte imbalance, if there's a congenital abnormality or a conduction path abnormality. With paediatric synchronized cardioversion, this is a very rare thing to have to do, but the progression of synchronization should be 0.5 to 1 joule per kilo to start with, and then progressing to 2 joules per kilo if required. Again, just be aware that there is the potential for sparks, electricity, flammable materials, oxygen, all that just doesn't mix very well together. So just make sure that with your environment, you try to minimise hazards as much as you can. Also remember not to have any direct contact with the patient during the cardioversion. And just make sure that when you have the pads on the patient, that there is very, very little space between the pad and the chest, because this space can cause a spark hazard. When it comes to troubleshooting, if the synchronized cardioversion doesn't work, you may need to look at repositioning your pads, making sure the pads are in the right spot, making sure that the pads have good contact with the skin. The battery in the monitor might be depleted. You might need to change your pads, they might be damaged, anything like that could be going on. Also note that synchronized cardioversion can be performed during pregnancy without causing a disruption to the fetal rhythm. Also, caution is required in patients with a pacemaker or an implanted cardioverter defibrillator. Just make sure that when you place these pads on, that they're at least 12 centimeters from the device. Otherwise, you can cause a change to the setting of the ICD. You can damage the machine itself, the leads, or the heart tissue. So the equipment we'll need for this procedure is our defib LifePak 15. We're going to need multifunctional adult pads, which I've got here. We'll need our sedative agent, so we can use ketamine at 1 milligram per kilo IV or 4 to 5 milligrams per kilo IM. We can use midazolam at 2 to 2.5 milligrams, or we can use propofol at 0.5 to 1 milligram per kilo. We're also going to need to have our masks, our BVN, our suctioning, all that sort of stuff ready to go. Monitoring equipment such as our blood pressure cuff, oxygen sats. We want to have our IV access also ready to go. Alright, so with the method, we're going to want to confirm with our partner on the machine that we do have a cardioversion rhythm. Next, we'll explain the procedure to the patient, explaining the risks and the benefits, and gain their consent. From here, we'll establish IV and have Hartmann's running to keep the vein open. We want to ensure that we've got our resuscitation drugs ready to go, our ventilation, airway and suctioning is ready to go and functioning. We'll start to oxygenate our patient at 8 litres via the nasal prongs, and then we'll begin sedation. Alright, from here we want to make sure that the electrodes we have for the 12 lead are moved out of the way, and when we place the defib pads on, we can either go anterior and lateral, or we can go anterior and posterior. Anterior-posterior is preferred because it gives a direct current through to the heart. Just noting when you place the pads here to make sure that the chest is clean, dry, free of hair and free of lotion. When you put the pads on, make sure it's in a rolling motion to make sure that there is no air pockets, as this can be a spark hazard. We want to ensure that the light pack is in manual mode. Press the sync button until the light turns green. It will start to blink when the QRS complex is being detected. You want to ensure that the R wave is being marked and sensed by the machine, indicated by a small triangle that will appear at the top of every QRS complex. This will ensure that the shock is delivered at the right time and not depolarize the T wave. From here, we select our appropriate energy level. The first shock will be delivered at 100 joules. If we proceed to a second shock, it will be delivered at 150 joules, and the third shock will be delivered at 200 joules. We will press charge and follow standard precautions to clear the patient prior to delivering the shock. Note that there will be a slight delay as the machine times the delivery of the shock. Once the patient has been assessed as being clear, we can deliver the charge. We reassess the patient and rhythm after this shock before proceeding to our second charge of 150 joules. Note that a maximum of 3 attempted synchronized cardioversions can occur, ensuring that synchronization is applied prior to each shock.